So we're going to be going over the insertion of a cordis today. And the reason we're going to be doing this is both for potential insertion of either a transvenous pacemaker or Swan-Ganz catheter. In this case, the first thing I would do is make sure that you have all of your equipment ready on your right-hand side. We would use for a Swan-Ganz pacing catheter a 6 French cordis. That would accept both 4 and 5 French pacing catheters, whereas we would use the 8.5 French cordis if we're trying to put a Swan-Ganz hemodynamic monitoring catheter in, which is typically a 7 French catheter. Obviously, as with all central line insertions, ensure to make the patient is well prepped and draped. So obviously you would do all the cleaning first, followed by draping, which we have already done. Make sure that the patient is appropriately positioned, specifically in the Trendelenburg position, because you want the venous system to be engorged prior to insertion of your catheters. And finally, make sure that the patient is ready and has been consented for the procedure, which obviously we would have done prior to this. So once we have done all of these things, I think the best thing for us to do is to now just quickly have all of your equipment ready on your right-hand side. So on your right-hand side, you can see from left to right the equipment required first to do local anesthetic injection, followed by the actual initial needle for local anesthetic injection, the seeker needle for the wire to go in. After that, you will have the actual scalpel that you will use for cutting the skin. This is followed by the actual wire that you're going to use to insert into the venous system. You then have a dilator. Now, in a cordis system, the dilator is very different to the dilators used on standard central lines. And so what you should do to prepare yourself is to put the dilator through the back end of the actual line itself. And it is also best to use some saline fluid in both of the lines in order to prepare it, because all of these are hydrophilic wires and hydrophilic lines. Finally, going to the other end of the table, we have the covers. One is the cover used for the pacing catheter, and the other is the cover that is used for if you do not have either a pacing or a hemodynamic catheter in. This would be used to keep the area sterile in case you are not ready to put the pacing catheter in. So let's move on. We have the patient prepped and ready to go, and obviously you have all sterile technique and yourself in gloves, gown, and appropriate head covering. So next we'll get the ultrasound machine prepared. Your assistant can help you. You will use the ultrasound machine. First, there needs to be gel on the ultrasound machine on the outside of the actual sheath. And so we'll get you to put some gel on the inside of that. Perfect. And then you can extend your arm out to your assistant, who will give you the ultrasound machine, pull the sheath all the way down to cover, and then use the 2 rubber bands to prepare your ultrasound. Obviously, with ultrasound, you want to make sure that there is no air in the interface. That's why the gel is very important on the inside and the outside, so that you get good sonographic images. Notably, we're going to be inserting this as a right-sided internal jugular line, because for both Swan-Ganz hemodynamic catheterization as well as pacing catheterization, the right internal jugular is the straightest shot to the heart, and therefore this is the easiest place. The lines can be inserted in other areas, but often done under fluoroscopy. So let's now take a look under ultrasound to see where our internal jugular is compared to the carotid. Ideally, when you're using ultrasound, it would be good to turn the lights off so that you can appropriately see. So once again, once you have your probe on the neck, you want to be able to identify the carotid artery versus the right internal jugular. The carotid artery typically will be pulsating at the heart rate that the patient is going on. The IJ, you should confirm that it is compressible, and in general, the internal jugular should always be lateral to the carotid. So you want to make sure before you do any poking that you're 100% certain that you know which is the artery and which is the vein. Any needle that you insert into the neck should be pointing laterally so that you do not cause an arteriovenous fistula or that you accidentally or inadvertently have a carotid puncture. So once we have successfully identified the internal jugular vein, I'll get you to get your initial needle for local anesthetic set up and ready to go, and then we can instill some local anesthetic into that region. The idea is to assist, especially in an awake patient. The freezing can reduce pain in the area. So we'll do that next. It's good to always do a skin bleb as well as to inject into the subcutaneous tissue. Perfect. Once we do that, we'll wait a few seconds to let the local anesthetic work. But once the local anesthetic has had time to instill, we will next get our seeker needle ready on another syringe. And it's always good to have your wire close by to you, because this is probably the most critical aspect of any central line insertion, which is wire insertion. So yes, it's always good to have the wire very close. So then we will get the visualization again under ultrasound. It is always good to make the needle on the seeker needle a little bit loose so that it is easy to remove the needle quickly with one hand. So we will once again look for the internal jugular again, because we have dropped the ultrasound probe. It's good to reconfirm our location, that it is lateral and that it is compressible. So we will now insert the seeker needle a centimeter or two beyond where the probe is, with the idea being that we will want the needle to hit the vein at around the plane where the ultrasound probe is. It is good to fan with your ultrasound machine to try and look for the actual tip of the needle, and also moving the needle forward and backward will allow you to also see movement on the ultrasound. This needle should always be pointed lateral. You should never be pointing a needle in the neck medially, because it increases the risk, as I mentioned, for arteriovenous injury. In this case, once you have fluid, it is best to drop the ultrasound probe, stabilize the needle against the patient's face, remove the syringe, and then with your right hand at approximately a 45-degree angle, push the wire in slowly. If you feel any resistance, it is important to stop and then reconfirm your needle position. The wire should flow in very smoothly, and once it is in, good work. Once it is in, remove the needle. Remove the needle. Excellent. And now your wire is in. Post-wire insertion, it is always good to reconfirm on ultrasound. So it is best to recheck on ultrasound that your wire is in the vein and you can follow it all the way into the vein. It is also good to switch to longitudinal view to see the wire go into the venous structure. And this is important to do prior to any dilation. Even if you have a carotid puncture at this time, if you've not dilated, you have significant more safety. Our next step, now that the wire is in, is to make a large skin nick. This is where we use the scalpel. So again, to be clear, scalpels are used for skin nicks, not for subcutaneous tissue. That's for the dilator. It is important to make a large skin nick in order to ensure that the dilator and the cordis can go in smoothly. Once you do the skin nick and recap your scalpel, you will use the combination dilator and cordis together that already has fluid in it. Both go together unlike a central line, and you will put it over the wire. Once you put it over the wire, you will want to make sure that you have one side of the wire in your hand prior to pushing it in. As always, you never push wires into patients without having control of one side of the wire. As you're pushing in, always hold the dilator and the cordis proximally. Push the dilator and cordis in a centimeter or two, then ensure that the wire is free flowing to ensure that you have not caused skin-related kinking of the wire, and then continue to push until the whole dilator and cordis goes all the way to the skin. Perfect. Once you do that, take both the wire and the dilator out at the same time. The back end of the cordis will self-seal. And at this time, it would be good to flush the outside line as well. You've already given fluid, but it would be best to also flush the outside line. The last thing we will do after this is to secure the cordis in place. The cordis can be secured with the use of a suture. As you can see, it's got a little ring on it that you can put a suture through in order to secure it to the patient's face. And if we're not going to be inserting a pacing catheter or a hemodynamic catheter at this time, you can cap it with the smaller cap. It's rotated on in order to keep the area sterile. So we will do that now, and then you can reopen it when we need to put a pacing catheter in, for example.